This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. All right, welcome everybody to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you who are new here, I'm a med-peach-trained pediatric hospitalist here at the University of Pittsburgh, Children's Hospital of Pittsburgh. We've been coming to you with this podcast since October of 2016. And what we have now is these very special Journal Club episode series we've been putting together. We've been trying to discuss different topics that are on the American Board of Pediatrics content specifications for pediatric hospital medicine. And we always try to discuss contemporary topics as well, like viruses and COVID, etc. And we have been looking for years to try to figure out how to cover the research part of the content specifications for anybody, right? For pediatricians, for anyone. How do we review that in an audio-only format? How can we learn to help critically evaluate the literature? And this is hard to do in an audio-only format. So to try to pull this off, we've partnered with our colleagues at Dell Children's Medical Center and Dr. Philana Ling Lin at University of Pittsburgh. And we have a group of experts with us, both from the University of Texas at Austin and the University of Pittsburgh. And you're going to meet them throughout this series. And without them, we could not have done this, because if you've listened to this podcast at all, you know I am not an expert in biostatistics, so I would not have been able to do this. So with us today is one of our expert guests, friend of the podcast now. This is the second time around. Dr. Matthew Wilkinson. Now, just in case you've heard him for the first time, Dr. Matthew Wilkinson received his BA from Harvard University, his MD from the University of Connecticut, and his MPH from the University of Texas. He completed his residency in pediatrics at Children's Hospital of Austin and his fellowship in pediatric emergency medicine at Phoenix Children's Hospital. He currently works in the emergency department at Dell Children's Medical Center in Austin, Texas. Dr. Wilkinson is an associate professor of pediatrics, the research director for the Pediatric Emergency Medicine Fellowship, and the assistant chair of clinical research at the University of Texas at Austin Dell Medical School. He has published several industry-funded drug and device trials relating to the treatment of acute pediatric asthma. His other research interests include pediatric fever evaluation and procedural sedation. So, Dr. Wilkinson, thank you for joining us again.
Tony, thank you so much for having me. I really appreciate it.
Now, we have back-to-back episodes, Matt, so we're going to dive right in. Today, what am I thinking? We have to do our disclosures, right? It's a CME podcast. So I'll go first, Matt, and kick it out to you. I am disclosing that I was on a Sanofi advisory board for increasing vaccination rates in immunocompromised patients. That's all I have. It should have no bearing on what we're doing. Matt, now it's yours.
So I'm the co-founder and board member of a device company called EM Device Labs, and it also should have no relation to what we're talking about.
All right. Now that that's out of the way, Matt, this is going to be a general question to kick us off here, but this concept of relative risk and odds ratio is what we're talking about today, measurement of association and effect. Why is this important for us to know to be able to critically evaluate the literature for our patients?
Sure, Tony. Let's start by talking about relative risk, because I think it's the easier concept to understand. So let's say that there is a probability of disease. And let's say whatever the disease is, some type of cancer. Let's say our lifetime risk is 10%. There may be something that we're exposed to or something we do in our lives, like smoking, drinking alcohol. Something may increase the risk of that disease. And so when we talk about the relative risk, we're talking about, what is that increase in the probability of the disease or the outcome given the exposure? And so let's say I spend 20 years smoking, and my relative risk might be 2 or 3 times what my baseline risk would have been had I not smoked or had I not had some given exposure. So the relative risk is basically telling you, relative to the baseline, relative to the unexposed group, what is the increase or decrease in the risk of the outcome given that exposure?
I like that example a lot. So you're saying for smoking as an example, all of us have some risk of it, of having lung cancer, let's say. And then if I smoke heavily and you do not smoke, what is the relative risk increase in my case based on my smoking exposure that I'm going to have cancer? Did I say that right?
That's exactly right. Yeah. And so I think clinically speaking, this is probably one of the more useful topics related to, evidence-based medicine and research. This is something that, the average person really cares about. And so I think this concept, this term is really important to clinical medicine and not just, in the journal club or in the research setting. Because people want to know, there are things that we do in our life and maybe it gives us pleasure. For whatever reason, we do these things, but they also may have, deleterious effects on our health. And so people really want to know doc, I'm coming to you. I'm asking you, I do these things. They give me pleasure. I smoke, I drink, I eat fatty foods, whatever the thing is. What is that doing, to my chances of having a long, healthy life? And I think these concepts are really, really useful in the real world. So if I tell someone, look, you smoke and it gives you some pleasure, but you're increasing your chances of cardiovascular disease, of cancer, of all kinds of things. And then they're going to ask you, how much is it increasing those chances? And I think the relative risk is the concept that basically tells them, I am doubling or tripling or quadrupling, or in the case of smoking might be 10, 20 times your risk of having certain outcomes. And I think that's really meaningful to patients.
Now, can it work both ways then? Meaning, if you and I are two people in a study and you exercise heavily, you exercise every day and eat healthy foods, can we look at the relative risk of you living longer than I do, or would that work the same way?
Yeah, that's right. So relative risk can be, a big number, like say 2, 3, 4, greater than 1, or it can be a small number, a fractional number. And so if the relative risk is less than 1, basically what you're saying is it's decreasing the chances of the outcome. So if I flip it and I say, instead of smoking, let's say exercise is the exposure. Let's say 60 minutes of daily exercise is the exposure. My relative risk of cardiovascular disease might be 0.5. I may have reduced it by half, my chances of getting the bad outcome. And so relative risk can work both ways. So it could be a number greater than 1, which increases your risk of the outcome, or a number less than 1, which actually decreases your risk of the outcome.
Then I would assume 0 would do nothing. Your outcome is the same.
So 1 would be basically one would be the same. Yeah. So basically numbers less than 1, and it can't be 0, at least theoretically. But numbers less than 1 will decrease your chances of the outcome, and numbers greater than 1 will increase.
Very understandable, Matt. I expected it to be more complicated. That went really well. What about odds ratio?
So odds ratios are a little tricky. And I teach biostatistics to fellows and residents, and this is one of the concepts that I think they have the hardest time with. The idea that odds and probability are not the same thing, and people will use the terms interchangeably, your odds of disease, your chance of disease, your risk of disease, and they're not the same. So probability or risk is a proportion. And so it's a fractional number between 0 and 1. So your probability of an outcome can't be greater than 1 or less than 0. So if you have a 50% chance or a 50% risk of disease, 0.5, then there is a 50% chance that outcome will happen throughout your lifetime. Odds is different. Odds is not a proportion. Odds is a ratio of one thing to another thing. So in medicine, we talk about the odds of disease. And so if I say your odds of disease is 1 to 2, but that basically is saying there's 1 chance that you get the disease and 2 chances you don't. So it's a very weird thing and hard to understand. But if your chance is 1 to 2, if your odds is 1 to 2, there's actually 3 possible outcomes. 1 of them you get the disease, 2 you don't. So your probability is 33%. And that's very hard for people to understand, this idea of odds, which is a ratio of one thing to another thing. And it's not the same as probability.
So if I understand this right, and correct me if I'm wrong, if I lived an infinite number of lives, like if I just kept on reincarnating and lived an infinite number of lives, and there was an odds ratio of 1 to 2 for me to get disease X, that would mean in a third of those lives, I did not get disease X. And in 2/3 of those infinite lives, I did get disease X.
So if the odds of disease is 1 to 2, it's
Right.
actually kind of the opposite. So in one of those lives, you get it, and two, you don't.
Oh, I see.
So if you so odds are one thing to another thing.
Okay.
So one chance you get it, two chances you don't. So there's three possible outcomes. One of the three, you get the disease. So you convert odds to probability, and 1 to 2 is the same as saying there's a 33% chance of disease.
Okay.
And that's a super weird concept. So that's odds. Odds ratios, basically saying, what is your odds of disease given exposure compared to your odds of disease not given the exposure? And so it's a ratio of ratios, which is a little bit
Yeah. Very straightforward.
make your head explode. And I will tell you, so people ask, why do we even have odds ratios? They're so complicated. They're so hard to understand. Why don't we just deal in relative risk, which makes way more intuitive sense? And the reason why is there are some scenarios where you actually can't calculate the risk of disease. And one scenario that I use as an example is case control studies. So in case control studies, basically you're picking the disease outcome and how many of those cases you have. And then you're deciding how many controls you want relative to those cases. So let's say we're choosing pancreatic cancer as our outcome. Very rare disease, hard to study. And so we choose a case control study to try and decide which exposures may increase your risk of pancreatic cancer. So to do that study, we are going to find every case of pancreatic cancer, in our catchment area we can possibly find. Let's say we have 20 cases. And then we want to enroll controls to basically compare the exposures in the controls in the cases. So how many controls do we put in that study? It's up to you as a researcher. You can put 20, you can put 40, you can put 100, because you gain a little bit of power each time you add controls. And then you go ahead and you look at the difference in exposures. Let's use smoking again. So it looks like smoking was 3 times as common in the cancer group. So we can calculate odds and odds ratios in that study, but you cannot calculate risk or relative risk because you don't know the prevalence of disease, because you set the prevalence of disease based on your study design. You picked 20 cases and you may have picked 20 controls. So it looks like the prevalence is 50%, but we know that's not true. The prevalence of pancreatic cancer in the population is not. So you can't calculate relative risk in that scenario, but you can calculate an odds ratio because the odds ratio doesn't change based on the prevalence. The odds ratio will always be the same no matter how many cases you picked or how many controls you picked. So that odds ratio is calculable in that study design, and it's fixed no matter how many cases, how many controls you pick. So in that scenario, you need odds ratios and you can't calculate relative risk.
So when you don't know the prevalence of the disease, you can't give a relative risk because you need that information.
That's exactly right. Yeah, you can't calculate risk, and so you can't calculate relative risk because you need to know the prevalence.
So,
and the reality is we can look at past studies and, other literature and figure out the risk. And so you can get an odds ratio and convert it to a relative risk based on knowing the prevalence from maybe prior research.
So then thinking about COVID for a second, when we were coming up with all of our studies early on in the pandemic, we really didn't know the prevalence of the disease because we didn't have great testing. So what we were really calculating there was odds ratios, things like we found out obesity makes you more likely to have severe COVID. And that was more of an odds ratio than a relative risk because we didn't know the prevalence.
And that's exactly right. And, early on in diseases, this is what the CDC does, right? They do case control studies when they're trying to find things that increase or decrease the risk of an outcome that's maybe new. And so that's absolutely right. So you can calculate odds ratios. You get a bunch of severe COVID cases, a bunch of folks that maybe had COVID with totally benign outcomes. And then you compare risk factors and you can calculate odds ratios. Now, the odds ratio, it's useful, right? So it's going to tell you that this exposure, this variable increases or decreases the rate or the severity of some outcome. But odds ratios will always overestimate the association. And that's one other thing that people should probably remember. So compared to relative risk, the odds ratio is always going to overestimate the association. So if you have an odds ratio of 4 for a disease, given an exposure, the relative risk is always going to be a little bit less than that, or it might be much less than that. It really depends on the prevalence of disease.
So then back to your we'll say back to your pancreatic cancer example. The way I would phrase that, so if we found out, so I just want to make sure I get the wording right. So if we found out smoking increases your risk, and let's say for every 3 cases of patients, I'm trying to say this correctly, for every 3 patients, if they smoked, I'm trying to say it's a 1-to-2 ratio, but how would I put that into words? If something's a 1-to-2 ratio, smoking causing or increasing your risk of pancreatic cancer is in a 1-to-2 odds ratio. How would I put that into words?
Yeah. So the odds ratio and the odds they're a little bit different. So if your odds of disease is 1-to-2 in the unexposed group, and then your odds of disease is 2-to-2 in the exposed group,
Okay.
then you make that your ratio because you've got the odds in the exposed group and the odds in the unexposed group. So the exposed group in the numerator, the unexposed group in the denominator, that gives you your odds ratio. So it's a ratio of odds, which is, I know, very, very complex and hard to understand. But the odds ratio basically is telling you, what is happening to your baseline odds if you're exposed. And so let's say there's an odds ratio of lung cancer of 10 if you're a smoker. Odds ratio of 10, which is not unrealistic. So 10 times the odds.
Okay.
So you have to calculate your odds at the baseline. And so your odds of getting lung cancer at the baseline, and then you multiply it by 10 if you're a smoker. So your odds might be 1 to 10,000, right? It's not a common outcome. And so if your baseline odds of smoking is, of cancer, if you're a smoker, lung cancer is 1 to 10,000, one chance you get it, 10,000 you don't, and then you smoke, you multiply it by the odds ratio, and so now it's 10 to 10,000.
Yeah.
So 10 times you get it, and 10,000 you don't.
Okay. So now I understand it. So you're multiplying your odds ratio by your baseline odds to get a certain disease to see how it's affected your chance of getting that disease. And it's always going to overestimate the relative risk, but it'll never underestimate it. So, okay.
Exactly right. Yeah. And relative risk, we can talk about it the same way. So if your risk of an outcome is 1% and the relative risk given an exposure is 10, then you just simply multiply it by 10. And so if you're exposed, you have 10 times the risk. So your risk went from 1% to 10%.
That is very, it seems so simple now, but it trips us up constantly.
Yeah. And, Tony, one other thing I want to talk about, and this is something that I think people will find very relevant to clinical practice. We talk a lot about odds ratios and relative risk, but you really need to think about it in the context of absolute risk, right? So simply telling someone that, drinking alcohol doubles your risk of what? Let's go back to pancreatic cancer.
Sure.
If you drink alcohol, you have twice the risk of developing pancreatic cancer. But that's only part of the story, right? So people drink alcohol for many, many reasons. But part of it is probably that they get some joy from it. So if I tell you that your risk goes from 1 in a million to 2 in a million, that's very different than saying it's going from, 1 out of 5 to 2 out of 5, right?
Yeah.
And so I think absolute risk is something you also need to understand and talk about and discuss with your patients, because that's the thing that they really come face to face with every day of their life. Simply saying that something increases your risk of an outcome by 10%, that's not as meaningful as saying, look, it's 1 in a billion and now it's 1.1 in a billion, Yeah. And so I think understanding both of those concepts is very, very important in the real world.
And I think we've started to do that with the febrile neonate guideline changes, where we really discuss more absolute risk with families when we try to decide whether or not to do an LP based on certain ages. We as a field have made that kind of adjustment.
And this is a concept I talk about with trainees almost on a daily basis. So whether or not you think this way deliberately, we make these decisions every single shift that we work. A child comes in and they're febrile, and it could be a 2-day-old, it could be a 2-year-old, it could be a 10-year-old. The 10-year-old's chance of meningitis is not 0, right? It's 1 out of something, but you're not doing an LP on that child, right? Because it's crossed some threshold where the risk is not high enough to justify the test or the procedure or the cost, if you think about it in terms of cost, which we should, and that's a whole different conversation we can have. But people, don't think about cost enough in medicine. But the chance is not zero. And then so you drop that age, and it's a 3-month-old. What's their chance of meningitis? A febrile 3-month-old who looks well. It's not zero. It could be 1 in 10,000. And then you drop the age to 2 weeks. And what is their chance? Is it 1 in 100? So we make those decisions every day, whether we're intentional about it or not. And so there is some threshold in there that we're all operating under, some risk that we're all either willing to accept or not willing to accept to do certain tests, to spend money, to do painful procedures. And so I really encourage folks to think more and more about that, because I think it's really critical to the way we practice.
Well, Matt, I don't know of a better way to end this episode. We're 21 minutes in. We've covered, honestly, quicker and easier than I thought it was going to be. Relative risk and odds ratio, association and effect. Is there anything about those two subtopics that we should, and we actually covered absolute risk, that we should have talked about that we did not?
I think we covered it. I think we went in many different directions and hopefully didn't make people's heads spin with the odds discussion. I almost, sometimes I think about just deleting it completely from everything, all my lectures and things I talk about, because I just get so many stares. But it's in the literature. It's something I think we have to deal with. We have to understand. And so hopefully that helped a little bit.
And then people can rewind and, play it again if not. But we're going to get feedback on these episodes. And if they want more on this, we'll be happy to give it to them. All right. So, Matt, Thank you very much for joining us. I really appreciate it.
Absolutely. Thank you, Tony.
Thank you for joining us for this Journal Club series at PHM from Pittsburgh. We want to especially thank our expert guests for their time.
Special thanks to the University of Pittsburgh for sponsoring the CME for this podcast, and UPMC Children's Hospital of Pittsburgh for supporting this podcast as well. We want to thank our friends at Dell Children's Medical Center and the University of Texas at Austin for their partnership on this endeavor.
Please email my dad at tony.tarchichi@chp.edu with any questions or comments. And as always,
thank you for listening.